I'm going to go ahead and dive into the presentation now. As we go through, please feel free to use the chat box for any questions that you have. We'll take a minute after each of the sections on the agenda to see if there are any immediate questions, but we should have time at the end for some good question and discussion period. And Eileen will be on hand if there are any acronyms that I use that you're not familiar with. Please call that out. I'm happy to revisit that or clarify any of the topics I'm walking through. So we're going to start with some background on CIVIC, the Center for Improving Value in Healthcare. CIVIC is the designated administrator for the Colorado All-Payer Claims Database, and we originally received that designation in 2011, and actually about 2 weeks ago, we received a 10-year extension of that administration, so we are the designated administrator now through 2036, which is a very strange number to We are a nonprofit that sits outside of state government, so we are not a state agency, we are not a part of a state agency. By statute, we have to sit outside of state government in the state of Colorado. The APCD must not be held by a state agency. So we have to be a nonprofit, nonpartisan, and independent organization. However, the APCD itself is an asset of the state that we operate and maintain. There are only 5 APCDs in the country that sit outside of the state agency, and CIVIC is the only standalone independent APCD in the country. Our statute also charges us to release the data to support Coloradans and to advance the triple aim for Colorado. So any of you who have used our data in the past will know that the application requires you to articulate how your research will be benefiting Coloradans specifically. The core functions for CIVIC include, in addition to maintaining and administering the all-payer claims database, include data extracts, public and contracted analytics and report development, program evaluation, research, and community engagement. So our mission is to equip the partners and communities of Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. Our core values are stewardship, service, integrity, and equity. We take this very seriously in the work that we do. I did put in here the actual language from the statute in Colorado because I think it is pretty interesting. It's a fairly unique charge. You don't find this in a lot of the APCDs, but you'll note the word facilitate at the very beginning of that. Our charge is to facilitate the recording of health and healthcare and health quality data, and to facilitate public reporting, to facilitate analyses of healthcare spending and utilization patterns. So we have a very clear directive to make sure the data is put to work for the people that are represented within the data. And that is something we take very seriously, and it is reflected across not only the volume of work that we do across the country, but also in the kind of quality of work we do for the state of Colorado. So our key partners that we work with are researchers, clinicians, hospitals, other nonprofits, government, basically anyone who is working to lower healthcare costs, improve care, and make Colorado healthier. And of course, we always want to make sure that we are keeping those consumers at the heart of everything we do. They're also at the heart of what the data actually represents. So we try to keep that front and center as we work with the APCD and other data. So a little bit about our reach. As I mentioned, our charge requires us to release data to support Colorado. We average between 110 and 140-ish data and analytic releases each year. That does not include the 300 to 400 free data releases that we do each year. We do have aggregated data available for download off our website, and we release hundreds of those data sets a year to support communities, to support counties. A lot of our local public health agencies use that data to support their community needs assessments. Lots of folks are using that data as well. And then approximately 60% of our projects are for Colorado state agencies. So we have contracts with, I believe, about 8 different state agencies and do work across a lot of the different focus areas within Colorado. Over the past 10 years, we've contracted with close to 300 different researchers and most major research institutions nationwide. Our work is limited to within the United States, but we have contracted with most of the major research institutions in the country and have been cited in more than 400 peer-reviewed publications. when we actually just this last year celebrated our very first peer-reviewed publication, written by our team on research that our team did. So we were really excited to see that progression in our internal research capabilities and capacity. So some background on all-payer claims databases generally. APCDs are large databases. They include medical, professional, and pharmacy claims, typically as sort of a baseline. There are obviously the advantages over a single payer or population-based database include that longitudinal care information on individuals across plans and over time. So being able to track churn in a population over time is a fairly unique aspect of an APCD and a very important piece of a lot of the research that is done with APCD data. Patient data that spans care settings and health systems. This is key for a lot of providers who may only get data through the EHR for care received in their own health system. Many HIE contracts only include data feeds from an individual health system. So if your patients are getting healthcare outside the system, that will not be reflected in the EHR. We also include data from most or all insurance companies across the state, including public and private insurance. And then it includes demographic, diagnostic, procedural, and reimbursement information, including total charges, plan paid, and the patient responsibility. I will say there is some variation across APCDs in what payment data is available, but Civic does have both the charge master rates and negotiated rate, and then plan paid versus member paid. And this obviously can be used for a variety of purposes, including policy work, but also research, clinical and health system performance evaluation, population health purposes, system redesign, et cetera, et cetera. I have an eyelash in my eye here. In 2020 and 2021, Doug McCarthy put together a series of papers for the Commonwealth Fund looking at APCDs and the purpose and value of APCDs. These are the 6 critical functions that he called out that an APCD should really be performing for a state. And Colorado was one of only 2 states in the nation who was able to actually serve all 6 of these critical functions for the state, for their state. So these are all activities and all work that we perform for the state of Colorado to support our state and the residents within it. A little bit about APCDs nationwide. So there are approximately 25 existing APCDs. There is a wide range of capabilities in data quality associated with those APCDs. There is varying allowable use and data release parameters. So one APCD's data governance model and release process is not going to look like another state's. They are very, very different from state to state. As I mentioned before, 5 of those APCDs sit outside of state government. Arkansas and Texas both house their APCD in the university system. So University of Arkansas at Little Rock and University of Texas at Austin, their data center holds their APCD. 2 states have a nonprofit that is co-located with their HIE. So both Delaware and Virginia have got APCD and HIE co-located under one nonprofit umbrella. And then there's one that's nonprofit APCD only, and that's Colorado and Civic. We've got 4 legislative language only states. So Montana, Tennessee, and West Virginia have all got legislative language but don't have an APCD. Kansas struggles a little bit. They have some basic APCD activities within state government, but I think that our friends in Kansas would say that it's not really a fully fledged APCD, but they do have robust legislation in place. And I do have to mention, I think West Virginia's language may have just been repealed. So they may no longer have legislative language. There are also 4 voluntary APCDs. So those are Oklahoma, Wisconsin, Missouri, and South Carolina. These are APCDs that allow payers to voluntarily submit data. The rest of the APCDs are mandatory submission APCDs. So payers don't have a choice. They have to submit. 8 to 9 states are exploring development, and 8 or 9 have no current activity. Many of those no current activity states are due to a lack of funds. These are going to be your smaller states like Wyoming, South Dakota, places where they don't really have the tax base to be able to afford to stand up an agency. So this is a slide I like to use just to give some example of what I mean when I say there's a wide variety of capacity and capability within APCDs. So on the less robust side, you've got some of the voluntary submission states. You're not going to be getting negotiated rates in those APCDs. It may be that they're only collecting data from state or from state employee plans and Medicaid. They may have limited public data release or very limited use cases, just a number of very significant limitations around the use of some of that data. As we get a little bit more into the more robust APCDs, we do encounter some limited mandatory submission. So some plans may be mandated to submit, others may not. There may be just limited fields that are submitted, so maybe not as robust as other APCD collection. And then again, these limited allowable data release and use cases. I think one that falls in between this and the next box here is, for example, Minnesota has actually an excellent APCD, but the use cases are so limited that virtually no one is allowed to use the data. So while the data is very robust, the use cases really, really truncate the ability of that data to be used to support that state. As we get into some of the more robust and broadly functional APCDs, we see mandatory submission across the board. CDL is the common data layout, and that's a sort of a base level common data structure that's created by the APCD Council and is widely available. We see a sort of easing of those allowable data release and use cases. Then we start to see data integration with things like vital statistics, discharge data set, and other state data. And then starting to get into the state use cases and really putting the data to work to support state activities, Medicaid agencies, Division of Insurance, et cetera. And then finally, we've got a few states that are in this kind of final bucket where you've got mandatory submission, both fields collected beyond that common data layout, that's for the baseline, and files, entire file types collected beyond the common data layout. Broad allowable data release and use cases, integration with other state and public data sources, and robust use in policy, public health, insurance, and other areas. This is where Civic sits. We collect several fields beyond the CDL, and we collect files like vision. We collect a number of custom files and data, drug rebate, and other items, which we'll discuss in just a moment. But you see some really, really robust utilization in the APCDs that are in this furthest right block. So the Colorado APCD. We have claims, receive claims for over 5.5 million lives monthly, and process bi-monthly to integrate those claims into the data set. We collect claims from commercial payers, Medicaid, Medicare Advantage, and Medicare fee-for-service. Medicare fee-for-service data access and use is governed by two different mechanisms. One is the Qualified Entity Certification Program, or QECP. Civic was one of the first 6 QECPs that were actually created in the country. That allows us to use the Medicare fee-for-service data for public reporting and eventually for provider purposes to support payment treatment operations for providers. And then we also manage the state agency authorizations for the state of Colorado, and this is the mechanism that allows us to use and release Medicare data for research. And we do also receive claim line level detail for Medicare Advantage. Though it is a capitated program, we get claim line level equivalents for individual procedures and for costs that are calculated by the different insurers that are running those programs. In total, we have more than 1.6 billion claims, representing over 10 million unique lives in Colorado from 2012 to present. And then, as I mentioned on the previous slide, we do also collect separate files in addition to some of that baseline, including our alternative payment model file. It has a monthly capitation file, drug rebates, value-based pharmaceutical contracts, and a file to support prescription drug affordability board. Those files are not currently available for research release, but we are working towards that. This is just a brief history of the Colorado APCD, starting in 2008, which was a Blue Ribbon Commission on Health, which recommended the development of the APCD and the establishment of a nonprofit entity outside the state to focus on improving the value in healthcare, which became the center to improve value in healthcare. And this just walks through some of our key milestones between that initial thought and where we are today. So what is submitted to the all-payer claims database in Colorado? This is a list of our monthly and annual files. So monthly receive medical, professional, pharmacy claims. We do receive a dental file in Colorado, not all APCDs do, and we also receive vision claims. Our eligibility files also include premium data, deductible data, and employer contribution when known. I will say this data is not super reliable at this point in time. We are working with our submitters to get more valid data in these fields. This is one of the newer additions to our monthly files, and we're still refining the data quality in this space. We also have an ERISA indicator. In 2016, there was a Supreme Court case that basically allowed any ERISA self-funded employers to get out of mandates for submission. You can voluntarily submit, and Colorado has worked very hard to encourage voluntary submission. And so we will actually indicate in the file if an employer is covered by ERISA, so we know who those voluntary submitters are. And then annually, we receive the drug rebate file, as I mentioned earlier, APM's value-based pharmaceutical contracts and the Prescription Drug Affordability Board. Under alternative payment models, we actually just last year or the year before began collecting APMs using the APCD Council non-claims payment common data layout, which does not use the HCP land categories. It uses more of an industry standard and also includes that monthly capitation file. These are some of the assigned identifiers and value adds that we create within our data. We're processing our data to improve the usability of the data by our team, as well as anyone else who's working with the APCD data. One of the pieces that is still sort of gaining traction and really we're still exploring how much it can be used is the geocoding of the APCD. So we did this back in 2021 to facilitate the ability to link this with the American Community Survey data and other census data. This does go down to the census tract level, census block in some cases, and allows us to do some really robust examination of variations in equity and access. Also important is what is not submitted to the APCD. So anything that doesn't generate a claim is not going to show up in the APCD. So the biggest issue here, we do not have any record of care for the uninsured. Anyone who doesn't have a claim going back to an insurance company is not going to show up in the APCD. We do have denied claims. So if you submit to an insurer and it's denied, we will see that. But if there is just fully uninsured, we don't see any of that activity. We also don't see any cash pay products or services. So anyone doing behavioral health therapy or nutrition services that's not covered by an insurance company or provider that doesn't accept insurance, that will not show up. Concierge or primary care or surgical services will not show up. And then some durable medical equipment if it's purchased outside of what's reimbursable by the insurance company will also not show up for the APCD. The other, I think, big issue is really those cash pay drugs. So anytime you have a high cost drug where they're using a pharmaceutical coupon, that will not show up. Any of those low cost generics at Walmart, Target, CVS are really saying that $4 for statins and thyroid meds and things, those also don't show up because those don't get run through insurance. It's just a low cost out of pocket generic those pharmacies offer. And then in terms of populations, there are the non-mandatory submitters. So as I mentioned earlier, the ERISA covered self-insured employers, those are voluntary submission only. We currently collect about 1 million self-insured lives in Colorado. And then the other big outlier is the federal programs. So Veterans Administration, TRICARE, the Defense Coverage, Federal Employee Health Benefit Program, and the Indian Health Service are not part of mandatory submitters to the APCD. This has variable impact on APCDs. Colorado is hit pretty hard by this one. Virginia is another one that has a huge population that are covered by these programs and went missing some years ago. So let's talk about the Cancer Registry. Switching gears a little bit here. So we have a really strong relationship with the Cancer Registry. We work with them regularly. They are housed at the Colorado Department of Public Health and Environment, and this is a standalone registry. So all of the registries and vital stats data and departments in Colorado are separate. So they have separate application processes, separate approval processes, separate parameters for data release. And so that the Cancer Registry is not connected to immunization, infectious disease, or vital stats. It's a standalone registry. The match is managed by the Colorado Cancer Registry in collaboration with Civic to ensure privacy and security. That's our number one goal for both organizations, is to make sure privacy and security is honored and that we are managing data use, to put the data to use while ensuring the highest level of privacy and security. So this process was carefully negotiated between the two organizations almost 10 years ago. And I have to say, and this was called out too when I was talking to our friends at the Cancer Registry, the collaboration and the level of the very positive relationship that we have, the constant level of collaboration across the teams is really why we are able to be as successful as we are in our relationship with the Cancer Registry. And then data transfer between the two organizations is allowable under a number of different mechanisms, not only our state business associate relationship, HIPAA research exceptions, but then also registry authority and the public health authority. So the Cancer Registry has data going back well before Civic's data is available. They have got 30 years of data available, and they have data on all cancers except basal and squamous cell carcinomas of the skin and cervical carcinoma in situ, and get approximately 25,000 cases per year. Researchers, public health professionals, government agencies, and others can access this data through a request process online. The approval process can take up to 4 weeks from data of application for just the Cancer Registry data. So the matching data with Civic's data can take an additional 45 to 90 days, depending on how complex the data being requested from Civic's side is. And we're going to walk through a lovely flow chart on this next page. My graphic designer just got this to me today. This is way prettier than what I could create. In both cases, so there's a separate application and approval process for both entities. So before any of this can start, a researcher has to apply at both locations with a separate application and go through the approval process. Once that approval process has been, once we've gotten approval at Civic, we can then create a finder file. So it is a file of the folks that we have on hand that have got a cancer diagnosis. Maybe you're limiting it to people in a certain zip code, or maybe you're limiting it to a certain demographic group or a certain kind of cancer. We send that finder file then to the Cancer Registry. So outside of the researcher, it goes directly to the Cancer Registry. What we include is the list of our folks that we have, along with any of the demographic identifiers we have. So name, social, address, DOB, whatever we have. We don't get socials for everybody, so we just send them whatever we can. And then if they've also approved the project, then move forward to do that match. They pull the data set into SAS for linkage, and they use MatchPro, which is a probabilistic matching program from IMS. They use that, and then they also, with all demographic data, and then they go through and do a manual validation for anyone who has less than 4 points of match, to make sure that those matches are accurate and to make sure that it's comprehensive. And now, depending on what kind of project has been approved, so many times folks are looking for a de-identified data set, and I'm going to know who the cancer patients are within this so that I can create controls. In that case, we send you the full de-identified data set of everyone in your universe of possible cohort members. And then the cancer registry will identify the cancer folks and your approved fields to receive. So tumor identifiers, markers, staging, diagnosis date, et cetera. They strip out the PHI, keep the civic identifier, send that file to you separately. So you will have two files with civic identifiers that you can match on that composite ID, that civic composite ID, to identify who has cancer with the cohort, and you get the additional fields from the cancer registry. If you're not getting the universe of everyone, or maybe you just want cancer information, or maybe you want more robust information on your cancer patients than other folks, in which case the cancer registry will send that file back to civic as well, so that we can validate which people are in fact cancer patients, or maybe we have to send a larger file because we don't know exactly who the cancer patients are within this universe of people. In that case, the registry will send you, the researcher, their data set, and also send civic the data set so we can match it, pull the additional fields in for that population, and make sure that you get that information and the identified data set. So it depends on what data has been approved for which, from which entity, how this process works. Obviously, if you've got to go to the dotted line and you're getting not only a limited file, but a de-identified file from us and a file from the registry, that is when it takes a longer amount of time because there's just a number of different steps. But this is basically the data flow that happens between civic and the cancer registries. Cancer registries on the bottom, civic is on the top. It seems complicated, but we actually have an excellent match rate. Overall, the match rate between Colorado APCD data and cancer registry is 93%. That raises to 98 to 99% for the public programs. So when you take our data and match it against the cancer registry, that's your match rate. When you take the cancer registry and match it against the APCD data, we have about a 74% accuracy rate, which is just about exactly what our known missingness in the APCD data is. So the VA federal employee data, the uninsured, and the ERISA self-funded that we don't have make up about 25% of the state of Colorado. And so it's actually a great validation for us because it should be in line with where we know our missingness is. Some of the fields the registry provides are diagnostic date, staging, vital status, tumor detail. They also have race ethnicity, which is a huge piece that APCDs typically do not have or don't have reliably. And then the APCD can provide details on the course of treatment, chemotherapy or pharmaceuticals, ancillary care, sites of care, cost, and all of those other treatment details. And together, they create a virtually complete picture of a cancer patient's journey. So I wanted to talk through just I've got 3 different examples of some recent research that uses matched data. At the end of this deck, which you guys are welcome to have, I do have a listing of just some sample papers and whatnot in the last couple of years that use the matched data. So this first paper looked specifically at the data infrastructure and the value of bringing these data together. Why do you want to bring together registry and APCD data? And so they looked at demographics, area level data, insurance, out-of-pocket expenses, post-diagnosis with cancer. They were able to look at over 91,000 cancer patients in this matched data set. I believe this paper only went 2012 to 2021, so it was a 10-year data set. They validated at 90+% match rate, and it noted the improved patient completeness, considering demographics, treatment, and cost dimensions, and then really called out the importance of being able to track cancer patients across insurance products through treatment. And I think this, I believe, only went through 2021, but I think even in years after that, we've seen more and more of this impact of financial toxicity on cancer patients, which is pushing more and more patients into public products like Medicaid or into different Medicare products. So being able to track that insurance churn is actually really important for this population. Some of the conclusions they called out that the Cancer Registry supplemented race and ethnicity and marital status, whereas the APCD supplemented coverage data and geographic data that allowed for linking to the American Community Survey and then looking at rural versus urban dimension. This is just a snippet of their demographic table. Just I wanted to call out the number of folks in unknown, missing, and other in the APCD race ethnicity category. I'm sorry, APCD is on the right. The Cancer Registry is on the left. We really have got some major gaps when it comes to race and ethnicity and APCDs. So this is a very important piece where the registry is able to really complete the picture of a patient. Next paper I just wanted to walk through is high-cost cancer drug use in Medicare Advantage and traditional Medicare. One of the reasons I pulled this in is because APCDs are really one of the only places, or the only place, to get claim line level information on Medicare Advantage. This is not data that is readily available in other places, and so we are seeing more and more folks using the data to compare fee-for-service or traditional Medicare with Medicare Advantage programs. This specific study looked at Medicare patients with colorectal or non-small cell lung cancer, and specifically was looking at differences in high-cost drug utilization between Medicare Advantage enrollees and Medicare fee-for-service enrollees. Just listed some parameters of the study here. They did use the APCD data to determine high cost when talking about drug costs, and they used the top 25th percentile from the APCD data to determine that. One advantage that this paper study called out was the fact that we collect data from Medicare Part D plans, so you can get supplemental drug data and also any standalone supplemental vision dental plans that Medicare enrollees may carry. And so that was actually pulled in to make sure they had comprehensive drug coverage information for this population. In the conclusion, they actually found that early stage colorectal cancer patients in Medicare Advantage were 6 percentage points less likely to receive any cancer drug. And those with stage 4 non-small cell lung cancer were 10 percentage points less likely to receive any cancer drug. If they did receive a cancer drug, the Medicare Advantage patients were 10 percentage points less likely to receive high cost for earlier stage colorectal cancer and 9 percentage points less likely to receive a high cost drug for stage 4 or more colorectal cancer. There was no difference in the high cost drugs for Medicare Advantage and fee-for-service, just because all non-small cell lung cancer drugs are expensive. So there wasn't really a difference. So overall, Medicare enrollment was associated with lower high cost drug use and potentially lower costs overall. I will call out, they did not include outcomes in here. They did not factor in survivability or survivorship or control for pre-diagnosis health status. So those are just sort of two call-outs, but this is a 10 percentage point difference. It's fairly huge. And so being able to dive into this a little bit more and figure out why that is and what impact that has on outcomes, I think is an important next step. But these are some of the things that we're able to look at because we can match these two data sets. And then finally, this is a really fascinating study that looks at disparities in radiation hormone therapy for women with breast cancer that are covered by Medicaid and those private insurance. And it looked at the Colorado Cancer Registry and the APCD separately and together. So when they went in, they controlled for race, ethnicity, age, location, year, diagnosis. They found some treatment underreporting, but substantially higher in the Cancer Registry than in the APCD. But interestingly, what they found is that if you just relied on the Cancer Registry data, there was a significant disparity in access to radiation and hormonal therapies for women on Medicaid compared to women on private insurance. But when you combine the two data or use just the APCD data, that disparity disappeared. And so their only disparity that persisted across all of those sources was an increased likelihood for women 52 to 63 to receive radiation within 9 months of surgery. So their point was really the validity of that data is dramatically improved when you increase or when you combine the two data sets. But they did know that it depends on having high quality cancer registry data and high quality APCD data, and not all states would be able to actually do that. I also want to touch on two community research projects that we have done that really get to this, what communities are doing to impact cancer and the effects of cancer on families, and sort of some of the work that our program evaluation team does at Civic. So first, we have a group called Carol's Wish. This is a program under the Colorado Gynecologic Cancer Alliance, and it is a financial advocacy and insurance optimization program. So their process is to help people navigate changing insurance products, finding grants, and in other ways, just making sure they can maximize the benefits that they have while dealing with gynecologic cancers. So our team looked to evaluate these two questions. Do they pay a lower out-of-pocket than non-participants? And does the program support under-resourced individuals? So there were 234 enrollees with claims in the Colorado APCD and diagnoses in our target time frame. And we looked at out-of-pocket amounts and total allowed amount. Looked at out-of-pocket for both cancer care and total medical care, and then pharmacy claims. And found that Carol's Wish enrollees were able to access almost twice the total medical in 6 months after diagnosis than non-enrollees, with significantly higher spend in cancer-specific care. They did see an increase in out-of-pocket costs, but it was 2.4% and did not reach significance. So really, and in addition, they also found grants and other things that ended up with a net decrease in their out-of-pocket costs, but purely from an insurance standpoint, the increase was only 2.4%, really showing that Carol's Wish was able to make a significant impact on individuals in this program, and those who benefited most were the highest need folks. So we used the Johns Hopkins ACGs to group by resource utilization band and comorbidity, and found individuals with the highest pre-diagnosis use and highest number of comorbidities with highest social needs were the ones who benefited most from the program. But overall, a really, really strong and fantastic outcome for this group of folks. The next one I'm going to highlight is Project Angel Heart. So this was the very first program evaluation work that we did at Civic. Started in 2017. Project Angel Heart is a Colorado-based nonprofit, and they advance food as medicine, but they focus on providing meals, medically tailored meals to Coloradans with life-limiting disease. So specifically, they focus on MS, COPD, CHF, cancer, ESRD, and HIV/AIDS. They do 2 different registered dietitians and a James Beard Award-winning chef on staff to make delicious and nutritionally appropriate meals for folks who are dealing with these conditions. Most of their enrollees have multiple conditions. It is very rare that they only have one. And so what they wanted to know is what's the impact on healthcare utilization and the costs for these individuals to receive these services. So we had a total cohort of 708 clients and that had claims in the Colorado APCD. We looked for folks who had non-$0 claims for at least 50% of each study period, and that were eligible for insurance coverage for at least 1 month of each period. And the periods were the pre-intervention period, so 6 months prior to the date they started receiving meals, the intervention period where they received meals from Project Angel Heart, and then the post-intervention period for those who did survive through the whole period and were able to come off of service. You'll note that the conditions on the right don't include cancer. The cancer is on the previous page. What we found going into this, and we'll talk a little bit more about this in just a second, we did not have a relationship with the cancer registry at this point in time. And we were not able to stage cancers. And so when we tried to analyze cancer like we did congestive heart failure or end-stage renal disease, what we found is that cancer gave us absolutely nonsensical output. The numbers made no sense whatsoever because we were jumbling everything up. And so we ended up cutting cancer from the final analysis of this study. because of the complications from our lack of knowledge on the staging process. So we were able to show some pretty significant impacts, of the intervention. We did see across all payers and all diagnoses. I know that the chart here is CHF, but across all diagnoses and all payers, we saw a 13% decrease in the rate of 30-day all-cause readmissions for the total population. We also saw a 14% decrease in total medical costs for Medicare recipients and a 24% average reduction in cost for congestive heart failure, COPD, in the diabetic patient. So here's just looking at some of that. We did see across the board a very common pattern where costs would decrease during the intervention period, and after they came off service, we saw those costs increase once more, sort of connecting the impact of that direct intervention on utilization and costs. We also saw decreases in length of stay. So inpatient visits decreased, but the length of stay for inpatient visits had a more notable drop. I think we had a drop of, I believe it was 5 days average inpatient stay for populations that were on service. There was a lot of anecdotal evidence that these individuals were able to better afford medications and had more energy, were better able to manage recovery after procedures. But this was the first time we'd actually been able to demonstrate that with data. And again, no cancer cases. So this was the initiation for us to start our relationship with Colorado Cancer Registry. As a result of the study, we realized the impact of having that additional data, the data diagnosis, the staging, tumor details, to be able to do work like this. So this was actually the project that initiated our relationship with the Cancer Registry back in 2017. Following the study, they were able to use this data to start establishing contracts with health systems across the state. Colorado Medicaid became one of the first Medicaid agencies in the country. I think we're vying with California as to who became the first one to reimburse for medically tailored meals for eligible Medicaid recipients. The increased financial stability led to increased services. Project Angel Heart now serves more than 2,500 square miles of the state and ships their meals all over. And in 2025, they celebrated their 10 millionth meal delivered and credited this study for allowing them to get there. We are currently in the process of designing the next iteration of the study, which is going to include expanded measures, dose dependencies, cancer registry linked data, and more. So we are actually right now in the process of figuring out the timing it looks like. That will likely be end of this year and going into 2027. So we've got some time for questions. If anyone would like to, or discussion. Any questions? Thank you.
Let's stop sharing your screen.
Oh, seems there.
While we're waiting for questions, I could just start. Thank you again. It's a fantastic presentation. You could just start with that Project Angel Heart that you ended with. I mean, it's such just a fantastic example, of the day-to-day impact. Were there things that stand out or that you learned with that sort of collaboration, that evaluation, that you're like, wow, this was something that worked so well here, and we want to do more of that? Or what were the
that was actually also the impetus of our program evaluation team. And so we've always had a really significant connection to our community and wanting to serve our communities. And this was an opportunity for us to not only say, this is our way of giving you the basics that you need to become sustainable, but they're not the only ones. And there really is a lot of work that we could be doing to support our communities in this specific way. And so we also learned that we really need specific program evaluation analysts, that grabbing some claims analysts that have been doing, data quality here and a little bit, reporting over there. It's tough for them to sort of flip the script and do some program evaluation. This is actually one of our first times. We really reached out to University of Colorado and reached out to I think Brown University of Colorado, and one other I'm not remembering right now, to help us figure out what is the how do we do this? What's the way we're doing this? It was our first time doing a propensity match for a control group. And we needed somebody to be able to come in and say, hey, are we doing this right? And so it was sort of the beginning of really more in-depth relationships with universities, being able to build on that, create some of our own research and program evaluation, and then in addition to cancer registry and whatnot. But we have done now, I mean, we saw the Carol's Wish piece, but we've done work for probably a dozen different community groups, even foundations. We had a local foundation that reached out because they needed program evaluation for one of their key portfolios. And so that group is really doing some incredible work. They did an evaluation of a tiny home village with that kind of facilitated mental health services and what that did in terms of impact. We're looking at a food as utility model and evaluating the impact of providing food to families in need as sort of the baseline utility type thing. So there's a number of different really innovative programs that we're able to look at right now because of the groundwork of that.
Yeah, awesome.
Jessica Archibald, raise your hand. Jessica.
Hi, good afternoon. Thank you so much for this presentation. It was really interesting. I currently work at the Shep Center for Health Services Research at UNC. And so we actually have a pretty robust database of claims, although it's not set up like a all-payer claims database like you all have. And a question that I get a lot from researchers who are interested in using our claims data are interest in working to compare trends in North Carolina to trends in other states. And so I was wondering if, I know you mentioned that with this data source, it's really set up and designed to improve the health of those in Colorado. So I was wondering if there was any requirements for projects that are interested in using the claims database that you all have, if they have to be located in Colorado, or if in some projects that can be a benefit to both North Carolina and Colorado comparing those trends.
100%. It is. We are not in any way, shape, or form limited to the program or the researchers being in Colorado. We encourage folks to bring the data together with other kinds of data to develop additional insights. As I mentioned, Stanford is actually a huge partner of ours. They use our data all the time in a wide variety of projects. And so, no, we 100% welcome partners outside of Colorado. There just has to be, in the study design, there has to be a benefit to Colorado. It can't, it's mostly to weed out the folks that are like, I want to use this because I'm an ambulance chaser and I want to, target people who had a car accident. But no, it's absolutely, we welcome projects from outside Colorado.
Awesome. Great. Thanks to know. And it sounds like a great resource. I hope one day North Carolina can have something similar. So thank you for your presentation.
Sure. Any more questions? Not all at once.
There's someone that's raised your hand. That's Marvin. Oh, Marvin.
Hi. Thank you so much for this presentation. And I know we're meeting a bit later, but I did have a question about sort of your matches with the cancer registry. I know that you sort of gave a rationale for why the back matching was around 73%, I think you said. And I'm wondering about the match to the cancer registry and why you think it was around 93%. Was that just because of out-of-state diagnoses, or do you think that there's something else going on?
You mean for the, I'm sorry, so you mean why it's not 100%, why it's only 93%?
Well, yeah, or not, yeah, 93%. And obviously 100% is not achievable, but yeah, I'm just wondering in terms of that, what do you think that amount is? Is it really just out-of-state diagnoses that you're not getting then from the cancer registry?
Well, the cancer registry should be getting out-of-state diagnoses. I honestly, I don't know what it's from. It could be, I have no idea. I have no clue what that is. I know that, our Medicare programs and our Medicaid program all have a 98 to 99% match rate. So I don't really know the source of that variation and why the private insurance is going to be lower and pulling that down to 93. Couldn't tell you. Sorry. I can go harass our friends at the cancer registry and find out what they think that is.
Yeah, it would be interesting. I mean, because obviously, again, you're able to sort of provide that rationale for your data, and it would be really interesting to see about kind of what's driving that and what kinds of patients aren't being covered.
Yeah,
Thank you.
yeah, sure. Sorry, I don't have more info on that one.
All right, well, thanks so much. Really
Thank
appreciate
you.
it. This was fantastic.
Yeah,
Thanks for being here.
absolutely.
I thought I knew.